everyone, and welcome to tonight's webinar on facial trauma. So as Aaron was saying, my name's Janhvi. I'm a MaxVac specialty doctor currently working in London. So I've done a dentistry degree first and then done a medical degree. So this is just an overview on what to expect with facial trauma, how to refer, and kind of the things to look out for. So our learning objectives from the webinar today is to be able to take an accurate history, a thorough examination, know what investigations to order, and then we're going to briefly talk about how to manage these facial fractures, as well as talk about facial lacerations and dental trauma. So just an introduction. So the reason, well, I think this is important for all healthcare professionals to know about is because facial trauma very commonly presents in both emergency departments and primary care. And I saw we have a lot of paramedics, and this is quite a common call that we get. More advanced facial trauma will very clearly be redirected to a major trauma center. However, more simple trauma can end up in many different places. And the reason it's so important is because obviously in the face, we have many vital structures. So it's essential that all healthcare professionals can assess these injuries and know when it's best to escalate appropriately. So just to start with, we're going to talk about a brief case. So we have a 50-year-old male who presents to the emergency department following an alleged assault to their face. So if you just have a think or pop it in the chat if you feel like it, what further information would you want to ask the patient and find out from them? I'll give everyone a few seconds to have a think about that. Have a look at the chat. Yeah, perfect. Everyone's having good thoughts already. Give it a few more minutes and then we'll go through it. Yeah, great. I think Lawrence has summarized it really well. The who, what, when, why, and how. Okay, great. So yeah, as we were saying, so we want to know when, who, what, how, where, and why. So the main presenting complaint and symptoms. So what is the reason for coming in? It might be very obvious, but what other symptoms are they getting? Exactly when it happened. And we often find with a lot of our assault victims, sometimes they've been intoxicated or depending on what's happened, they do present a lot later. And it could have been a few days ago that this happened. What was the exact mechanism of injury? So this obviously depends on what the cause was of their injury. So for example, if they had a road traffic accident, we want to ask whether the passenger, the driver, were they wearing a seatbelt, were they wearing a helmet if it was on a motorbike? If they were assaulted, we want to know how many people assaulted them, exactly what happened, were they punched, kicked, any weapons used, where exactly they were hit. If they had a sports injury, you want to know what sport they were playing. And if they had a fall, what was the cause of the fall? And did they fall from a height or just while standing? Obviously, sometimes these facial injuries look quite extreme, but it's important to make sure that there are no other bodily injuries. If there's any police involvement, and it's common with our assault victims. And like everyone was saying in the chat, we really want to rule out any intracranial injuries. Have they had any loss of consciousness, vomiting, nausea, and headaches? Obviously, ask about alcohol and drug involvement. So he says that he was punched multiple times to the right side of his face an hour ago by some unknown assailants. He did not lose consciousness, and his main symptoms are pain on the right side of his face, difficulty biting, and altered sensation. What sort of injuries would this make you suspect? So if everyone just has a think about that. And obviously there's loads and loads of different things that it could be. But what kind of things are you most worried about that this might be? Yeah, I think everyone's pretty much gone for it. So yeah, the reason we're most worried is that they've got a jaw fracture. But yes, like Maria has said, it could also be a cheekbone fracture. It could just be a dental break or a problem with their teeth. But yes, we're really worried about a fractured jaw because this can cause an airway compromise, and that's why this needs to be seen to right away. So what I'll do is I'm going to talk about the examination, and this relates to all facial trauma. And I feel like everyone has their own way of doing it. I find it's easiest to look from the front, and then I do a head to down approach. And I think that's easy to make sure then we don't miss anything out. So if we start with general inspection, so you want to look at them head on, and then you want to look all around as well. So have they got any wounds, bleeding, burns, any swelling or bruising, and any obvious facial asymmetry? And sometimes if you do suspect some asymmetry, but you're not sure, it's nice to ask the patient, do you have an old photo of you so we can see? Sometimes people just have asymmetric faces and it's hard to tell. Then if we start from the top and we work our way down, so if we start with the cranium, so you want to palpate for any deformity or depression, any obvious like skull fractures, and you want to assess the external auditory canal, just make sure there's no blood or cerebral fluid coming out of there. And then also assess the ear for soft tissue injury. So are there any lacerations or any hematomas? And then working our way down further, so we get to the frontal bone. And here you want to really be sure to palpate for any deformity and also to assess so we'll go through the thing, but to assess the trigeminal nerve. And as we know, the trigeminal nerve is divided into three. So the top, the middle, and the bottom. So this is a good chance to just test sensation at the top. You don't need to do a full kind of neuro examination, but if you just say, does this feel the same on both sides? Do you have any tingling? And just kind of use your fingers as light touch. And yeah, we'll go through why that's important later on. And as you can see here, there's an obvious depression in this patient's frontal bone. And sometimes it's really clear, but sometimes you really need to palpate to be able to see it. Next, we'll move down to the orbit. Now, this is really crucial, this stage, because obviously eye trauma can be life-changing and kind of devastating if it's missed. And there's a very short period of time when someone has severe eye trauma where you can reverse it. So the first thing to say is we need to make sure to inspect the eyeball itself. Even if it's severely swollen, we need to make sure we're looking inside the eye. And often I get calls and emergency department practitioners are just unable to look. And what a good way of doing it is if you use your fingers, normally the reason the eyelid is so swollen is because of air, and you just push either side, either with your fingers or with a cotton wool roll, get rid of the air, and then slowly, slowly pry the eye open. And you have to warn the patient that obviously this is going to be very painful, but it's only going to be a few seconds, and it's really important that we check. And at that stage, it's really good to have a second person there. So one person can open the eyelid and the other person can do all these other tests really quickly to check everything's okay. When we look at the eyeball itself, we want to look if there's any subconjunctival hemorrhage, so any redness of the sclera. And then palpate the orbital tissues just around and the orbital rim to see if there's any steps or any emphysema or tenderness. As well as looking from the front, it's really important, as it shows in this picture, to look from the top, head down, and you can put their head back and look from there. And the reason for that is to check for any proptosis. And again, we'll come on to why that's important and the consequences if there is any proptosis. We also want to look at the pupil reaction to light and to assess eye movement. And while doing that, just ask the patient, if you use one finger, is it still one finger or two fingers? And we also want to check for visual acuity. It's hard sometimes in A&E to do a full Snellen chart. It's difficult. Sometimes it's just better to say, is there any changes to your vision? Is anything blurry? Are you getting any problems? And unless there's really obvious visual acuity problems, it's normally something that can be assessed a bit later on formally. Next, we go on to the nose. So we want to check, is there any deviation or flattening? And this is a really good time to ask to see an old photo of them. Sometimes people just have slightly deviated noses. Palpate for any bony tenderness and inspect the nostrils for any rhinorrhea or blood. And you want to check the patency of each nostril as well. So just check their breathing. And you want to look from the bottom, like it shows in this picture, to look for any septal hematoma. So that's when the septum itself has a hematoma, and that can necrose very quickly. So if you do see that, and I've got a picture later on, it's important to refer to either ENT or MaxFax urgently for decompression. And then as we work our way down, we get to the zygoma. So with the zygoma, as you can see in this patient, there's obvious flattening. So you want to check for any flattening. You also want to check for trismus, so difficulty opening. And as well as trismus, you want to check for if there's difficulty opening. So you want to get them to open and then move their jaw side to side, so like this. And the reason for that is sometimes it can impinge on the mandible. And if that happens, obviously it's not nice to send them home and bring them back with that. So it's important to check. And again, with this, it's good to look from the top so you can really see their cheekbones, see if they're symmetrical, any deviation either side or any flattening. And you can see, obviously it's hard to look from that angle, but you look from the top, but you can see the cheekbones quite prominent here. And if one is broken, it's very easy to see if it's flattened. And you also obviously want to palpate for bony tenderness as well. And then as we move down, we get to the maxilla. So this is when it gets a little bit more difficult. And I think people aren't very used to looking inside the mouths of patients. So I like to divide it into extraoral examination and intraoral examination. So if we start from the extraoral, you want to palpate for bony tenderness, again, similar to all the other ones. You want to check for any deformity or facial asymmetry, and then check the trigeminal nerve again, so the maxillary division, to check if there's any numbness or paresthesia. Then once we look inside the mouth, we want to check for any malocclusion. And it's difficult when you're not a dentist to be able to tell exactly, but normally the patient will make it very clear. They'll say, this tooth is meeting way earlier and I just don't feel right. In this picture, it's very obvious that the back teeth are meeting, but the front aren't. But your teeth are so sensitive that even if there's a millimeter difference, the patient will definitely tell you that something just doesn't feel right when I'm biting. You also want to check the mobility of the maxilla. And you only want to do this once. So just put your thumb in the mouth and just move it and see if it is mobile or not. And the reason you only want to do this once is because if there is a fracture and there's bleeding, you moving it can really disrupt the blood vessels and cause kind of really bad hemorrhage. So you just want to do it once. And if it's mobile, you know that it's mobile. Don't do it again. Check for any defects or tenderness of the hard palate. So is there any bleeding, any obvious tears? And finally, look for any missing or fractured teeth. And we'll come on to this at the end as well when we go through dental trauma. But with the missing and fractured teeth, it's always important to ask what happened to that bit of missing tooth, or where is the actual tooth itself, and just check that they haven't inhaled it by accident and they've spit it out, or they know where it is. Okay, and then we'll move on to the mandible. Now, this is one of the most common, obviously, areas of fracture. And it's really clear. I'm sure a lot of you have seen it when someone has a mandible fracture, but it's really useful to assess it properly so we know the severity of it. So again, with the mandible, I like to split it into extraoral and intraoral. So if we go through extraorally first, you want to palpate the TMJ, so just here, and check the opening and closing with it, and see if they're in any pain. So is there any obvious breaks in that area? We again want to check for numbness or paresthesia in the mandibular division of the trigeminal nerve. We'll then also inspect for any facial swelling or deformity, and then palpate for any step deformities or bony tenderness. And it's really important that you assess the whole area of the mandible from the top to the middle. And even when you're checking for the trigeminal nerve, you check the lip, the chin, and the angle of the jaw, because sometimes different bits can be disrupted. And then if we look inside the mouth, we want to look for any dental trauma or obvious step deformity. Here you can see there's a gingival tear and there's an obvious step there with a break. Is there a sublingual hematoma? Nearly 100% of the time, if there is a sublingual hematoma, so bleeding under the tongue, then there is a mandible fracture, even if it's not obvious to see. So it's good to look out for and then do the right investigations to find it. And you again want to assess the occlusion. So is there a premature bite somewhere? With mandible fractures, it's really, really obvious. The patient will say, I can't close my teeth, and this tooth is meeting first. But doing that is useful to know exactly where the break might be. So we're suspecting a mandible fracture in this patient because of our examination and history taking. So what other investigations would you like to order? I think we've got a poll here that we can go through. And again, with this, there's not really any wrong answers, but it's just what is the most important thing we think we need to do for this patient. So I'll give everyone a minute.
The poll is now live.
Give it a few minutes, try to get as many people answering as possible. see if we can get to 50%, and then we'll see what we have. Okay, great. So we've got a huge variety in answers. And like I said, there's not really any wrong answer, but there are more right answers. So majority of you've actually gone for a CT head, which I would say is probably not needed in this patient, because if we look at the NICE guidelines, he hasn't had any loss of consciousness. It depends on whether, I mean, it depends on when you see him, what it's like. Has he got any obvious signs of trauma to his head? But often these patients don't actually need a CT head. CT facial bones is, again, obviously a good answer, but it depends on your examination findings. Do we think this is a really complicated fracture? Have they been hit many, many times with a weapon? If it's a single punch, chances are it's a simple fracture and they just need a plain X-ray and they don't need the extra exposure of a CT. An OPG, I would actually say, is the most important investigation, and I'll go on to why that is. Facial X-ray, again, is a good choice, but we'll see why other injuries might make this more easy. And yes, we would definitely need an X-ray mandible as well. So that's great. Great answers, everyone. And we'll go through all of the investigations now. Okay, so an OPG, or an orthopantogram. So this is normally something that most practitioners who are not dentists don't normally order. So this is a really useful examination to look at any dental trauma and any mandible fractures. And as you can see the whole mandible really, really clearly here, and all the teeth as well. And the way this works is you sit in an X-ray machine, and this X-ray machine moves around your head, and it creates a 2D image of a 3D jaw. So it's really useful to see if there are any obvious breaks. And sometimes it's actually easier to see on this than even on a CT, because you can, if there's a break, we'll come onto a picture of it, it's really clear. So if you're ever suspecting a mandible fracture or any dental trauma, really important that you order an OPG. And especially because a lot of units don't have MaxVac. So when you're referring patients, they'll always ask for an OPG. Next is a PA mandible. So this is just another view of the mandible, but this is a plain film. So it's taken just from the front. And sometimes it comes under PA mandible or X-ray mandible, depending on your ordering system. And again, this is really good for a mandible fracture. But the reason it's really important, again, OPG, is because of the spine. A lot of the middle of your mandible is kind of superimposed. So it's very hard to see breaks. And I've got some more photos and we'll see where that is as well. These are some either occipitomental views or facial X-rays. Again, different ordering systems have them written differently. And these can be done at any number of angles from your head tilting back. And it's just a plain film that goes at the front. And this is really good for looking at any facial fractures in the midface. So any zygoma, cheekbone, or orbital fractures. It's really good for looking at those. So if you're ever suspecting anything happening in the midface or the orbital area, really important to order this. And normally radiographers will do 2 views at 2 different angles, so you make sure you don't miss any of the important structures. CT facial bones. So I think definitely, and as you all probably know, in all hospitals, we're moving more to doing CTs, but it's obviously more difficult to get a CT out of hours, and sometimes it's just unnecessary radiation. So what I would say is most patients need a CT facial bones only if it's very complex fractures. If there's loads of fractures, so for example, if they have mandible, maxilla, orbit, everything, you can't do that many plain films. Easier just to do a CT. If you know it's going to be really difficult, it's better to get one for surgical planning. And one last thing that's a real bugbear of mine, especially with A&E doctors, is if you are requesting a CT head anyway, because they've had loss of consciousness, a CT head covers half of the orbit anyway. And that's the bit that you're most worried about getting radiation. So if you're ordering a CT head anyway, please order a CT facial bones at the same time, because it's near enough the same amount of radiation. And then if they need more imaging, you're just radiating the patient twice. And it's very easy. They're going for a head. You just do the face as well. So just bear that in mind. And obviously then it's really easy to see fractures. You can do 3D reconstructions and things like that. So these are the patient's OPG and PA mandible. So you can see really clearly, I hope everyone can see, there's a very obvious break here. But as you can see in the X-ray mandible, it's actually, you can see it, but it's not that obvious as it is in this. And this is quite a large break. If it was a smaller one, it would be even harder to see. However, conversely, there's obviously a massive break here, but on this OPG, it's really hard to see. So with all mandible fractures, it's really, really important to get two views. And that's because the shape of the mandible means that it's really easy to miss fractures because we can only ever get a 2D image of a 3D thing. So you need both of them in combination. And I've often had like conversations with radiographers and they say, oh, we don't need to do two X-rays. But no, it's important that you really stress you always need two X-rays for mandible fractures. And then it's really easy to see where the breaks are. So this patient has two breaks, and we'll come on to why that's important. So that's a brief overview of history, investigations, and examination. So that's going to be the majority of what you guys as health professionals will be doing before MaxFax or plastics or anyone else gets involved. But I think it's really interesting and important for you guys to know the management of these fractures so you can warn your patients, you know why you do the investigations that you need and ask the questions that you need to. So we'll go through them and also go through some red flags of what to look out for these patients. So first, we'll start with orbital fractures. So you can see on this X-ray, it's a bit hard to fully understand, but this patient has a left orbital floor fracture. So this is the orbit, and you can see there's a break here with a teardrop sign, and that's this soft tissue coming out. And it's hard to see. So I think with facial X-rays, it's always important to get a formal report or ask MaxFax to have a look because it is difficult to see. Conversely, in this CT scan, it's really easy to see. There's an obvious break there. So with orbital fractures, the reason that is such a common one is because there's natural areas of weakness in the bones around the eyeball, and that's to protect the eyeball itself. So if you get trauma to the eye, instead of the eyeball rupturing, the walls will break first, and that's evolution and how it's worked out. The most common places to fracture are the floor of the orbit and the medial wall. And it's important to remember that the floor of the orbit, as you can see here, is also the roof of your maxillary sinus. And that's why people often get blood and kind of air traveling all over their face as well, because the sinus is an air-filled pocket. They often present with swelling and periorbital bruising. They may have a restricted gaze, and that's because when the break happens, it can trap the muscles that control eye movements. And often this resolves once the swelling has gone down, but sometimes it doesn't, and those are the patients that need surgery. The reason we do surgery is often for cosmetic reasons. So if they have a big drop in eye pressure, the eye looks like it's gone in and it's dropped, or if it's functional. So if they're having ongoing diplopia or reduced eye movements, then we'll do it. If there's obvious eye trauma, so changes to visual acuity and things like that, or non-reactive or slow-reacting pupils, it's obviously important to get a CT head, get ophthalmology involved, get the neurosurgeons involved, but the majority of cases will only have bony injuries. These patients can often be discharged with having been seen by MaxFax. So all these patients need to be assessed by a MaxFax surgeon or someone, an A&E doctor who's experienced in these cases. Majority can be sent home and brought back to outpatient clinic in 5 to 7 days once the swelling has resolved for surgical planning or just for follow-up and no treatment needed. It's really important for these patients that they do not blow their nose for about 4 weeks after their injury. And that's often what it's important for you to see. Even if you're a paramedic and you see an obvious orbital fracture, they're going to A&E. Really important, tell them, don't blow your nose at all. And it's really tempting because there's often blood coming out. And the reason is because your sinus is there, if they blow their nose, the pressure can make a small break into an incredibly large break. So really, really important, tell your patients, don't blow your nose if you can. Really, really rare, and I don't think many of you will see this, but I did see there are a few pediatric professionals on here. Children don't often get these breaks because their bones are a lot more pliable. But if children do get it, very rarely, they can get something called ocular cardiac reflex, where they get vomiting and bradycardia with an orbital injury. And that needs urgent surgery and urgent assessment. But I've only ever seen one in all these years. So I think it's incredibly rare, but just something to keep in the back of your head. like I said before, really good to check for proptosis. And this is because we're checking for orbital compartment syndrome, or a retrobulbar hemorrhage, as it is often called. And what that is when most often blood, but it can be like a tumor, air, anything, gets trapped behind the eyeball, and there's nowhere for it to escape because there's walls everywhere. And what happens is you get increased swelling, and then the orbital, the optic nerve gets compressed, and it can be lead to loss of vision. And if this is not found within an hour or two of it happening, the patient can lose their vision forever. So if, as you can see in this patient, obvious proptosis, so their eye is sticking out, and swelling. The symptoms that the patient will have is loss of red vision first before they lose the rest of their vision, decreased visual acuity, a tense and painful eye, proptosis, so a sticking out eyeball, reduced eye movements, and very late, so do not rely on this as a sign, but if it's been going on for a while, they will get fixed and dilated pupil. This needs urgent decompression, either by MaxFax, ophthalmology, or an A&E doctor, and that's through a lateral canthotomy, which is basically when a cut is made just on the lateral aspect of the eye, and all it does is let the blood flow out, so there's no more pressure left, and then they'll need formal surgery after that. But this is one of the red flags that you really need to look out for, because it can be kind of devastating if it's missed. So with nasal fractures, we've all seen many, many nasal fractures. Isolated fractures are managed by ENT only, and they're normally seen in outpatient if there is no breathing difficulty or any other concerns. And it's seen in like 5 to 10 days once the swelling is resolved. Majority of these patients won't need any surgery, but obviously if they have aesthetic issues or breathing difficulties, they'll have a manipulation under anesthesia and a splint placed to keep it in place while it heals. A septal hematoma, so as you can see in this photo, the septum is swollen on both sides. This is an emergency and needs urgent incision and drainage. Like I was saying, it can lead to necrosis very easily. If they have a nasal fracture and multiple other fractures, they will need to be reviewed by MaxFax, and then they will deal with the nasal fracture as well. So normally if there's an isolated nasal fracture, often ENT don't even need to see the patient. You just assess and then follow up. But if they have other fractures as well, they'll need to be fully assessed. So mandible fractures. So the signs and symptoms of mandible fractures: obvious jaw deformity, pain and swelling in the jaw, altered occlusion, numbness or paresthesia of the inferior dental nerve. And the inferior dental nerve runs from about your TMJ all the way to your lip. So depending on where their break is, they can have most commonly numbness of the lip or chin. They can also have angle of the jaw and up to their TMJ. So really important to check the whole area. Now, the reason is that the inferior dental nerve goes through the jaw. So when you have a break in there, it's nearly 100% of patients will have some sort of sensory changes. Most of these come back after surgery, but very rarely it can be permanent. So it's important to warn the patient of that as well. And they can have a gingival tear or bleeding around the teeth in the lower jaw or in the floor of the mouth. So because of the shape of the mandible being kind of like a horseshoe, it's essential, like we were saying earlier, to get 2 radiographic views, so an OPG and an X-ray mandible. And it's really common, even with a single punch, I think about 50% of cases have fractures in 2 places. And that's because the way that the force is transmitted from a punch, it normally breaks on both sides, like we saw in the patient earlier. So it's really common for patients to be like, but I was punched on this side. How is my break on this side? And why am I feeling funny there? And then you can explain to them that it's a really common thing, and nearly all complex mandible fractures have this. Mandible fractures all need urgent MaxFax review, and they need to be admitted for nearly 100% of time for IV antibiotics, because it's an open wound into a contaminated field, which is the mouth, and they need an open reduction and internal fixation under general anesthesia. And that's normally done on the emergency list, because the risk with a mandible fracture is very rarely it can lead to airway compromise or a really bad infection because it's exposed. So it's really important that these patients stay in and they're counseled on what's happening and why it's important that they need to either go to hospital or stay in. And often these are people who have been assaulted. They may not want to come in. And it's really essential to explain to them why they need to. And normally this surgery is done in like immediately or within 2-3 days. These are some more pictures of some mandible fractures. So you can see this one is like a crack, and you can see it's nowhere near as displaced as the other one that we saw earlier. So you can not see it very obviously, apart from it's just very painful for the patient. And here you can see there's a little crack here, but you can see why it could be easily missed. And looking at this, there's another break up here by the TMJ on the left side. So it's really common when you see one fracture, really important that you always look for a second fracture. If it may be there or may not be there, but really important that you always check. Next, we come on to mid-face fractures. So this is called the Lefort classification. These rarely happen in isolation. And I think the reason they're called Lefort fractures was there was this French physician who was obsessed with facial trauma, and he got loads of skulls, chucked them off buildings, and he found that skulls tend to always break in one of three ways where there's areas of weakness. And that's why we've got this classification now. Because trauma is obviously more complex than that, it's rare that these happen in isolation. And by definition, they have to have a fracture of the pterygoid plate of the sphenoid bone. Not that that's important to you, but just if you read on the CT report, there's been a pterygoid plate fracture, this is what they have. So a Lefort 1 fracture is when the palate has dissociated from the rest of the maxillary complex, as we can see. A Lefort 2 is when there's a pyramidal break, so it's on the bridge of the nose, and that's gone down. And then a Lefort 3 is very rare unless there's massive road traffic accident. It's when there's complete craniofacial dysfunction. So the cranium and the face have completely separated. All of these will have mobile maxilla. So that's why we always check the maxilla as well. These patients, again, majority of the time need to be admitted and have surgery relatively fast because of the airway risk with them maxilla falling back. But sometimes they're really small and they actually do heal by themselves. So it depends on how big it is. Another mid-face fracture is a zygomatic fracture. So there's two things that you can have, either a zygomatic complex fracture or an isolated cheekbone fracture. A zygomatic complex fracture is because basically the zygoma has three connections, and if all three of them break, like you can see in the CT scan, the whole thing has come up, and that's when they have really obvious flattening, and they often have an orbital floor fracture as well. So if there's orbital symptoms and cheekbone, they've probably broken the whole thing. But quite commonly, and especially in sport injuries, we see isolated cheekbone fractures. So as you can see in this picture, it's literally just this crack that's happened. And these patients, again, can normally go home, come back, and they only get operated on if there's reduced mouth opening or if there's a functional deficit and an aesthetic deficit. Aesthetically, you can't assess straight away because they're obviously very swollen. That's why you need to bring them back to check if there is any obvious flattening or dimpling on that side. And it's a really simple surgical procedure to fix a simple cheekbone fracture. They don't even have plates or anything. It's just pushed out and heals by itself. Next, we have frontal sinus fracture. So we have this picture again, obvious flattening. And the reason I always bring this up is, so the frontal sinus, as you can see in the CT scan, is an air-filled pocket in your forehead. And you have an anterior table, so the bit at the front, and a posterior table, which is the bit at the back. And then obviously your brain behind it. So if only the front is broken, they might not need anything doing, and MaxFax will see them and maybe operate if they have functional deficit or there's a risk of infection. However, if there's a posterior table break and their brain is involved, it must be referred to the neurosurgeons. Often they might not do anything, just keep them in for observation, but it's important to know who to refer to. And those people will need both a MaxFax referral and a neurosurgical referral. So finally, we can see with this patient, so he had an open reduction internal fixation of his mandible done under general anesthetic. And these are the results. You can see he's had some plates put in. Now, with all of these breaks, it normally takes if they have an operation or don't have an operation, it takes 6 weeks for the bone to heal back. So normally, if they have either a mandible or a maxilla fracture, we say have a completely soft and near enough no chew diet for at least 6 weeks. Also, they should play no contact sport in that time, even if they have a fracture that hasn't been operated on. because it's just weak and can happen again. And you also warn them to come back, obviously, if they have any further symptoms. And then they just have a Maxfax follow-up. Often these people live with these plates forever. It's very uncommon, unless they're like a smoker or they have really bad oral hygiene, for these to get infected. Unlike hand and foot and leg and arm, because the face has such a good blood supply, it's, unless the patient really doesn't look after themselves, it's rare for these plates to need to be taken out because of infection. So normally they stay in forever. The only time is obviously if they're children, then we'd take them out as they're growing. So that's a quick summary of kind of all facial trauma. And I know it's a very whistle-stop tour, but I've just tried to keep it kind of focused on what you need to know when you're not working in like a specialist center. And what we'll talk about next is facial lacerations. And I think especially all the paramedics that are on the webinar today, is something you see super, super commonly. And often I get questions on, when do I refer patients? When can a nurse practitioner suture it up? When can an A&E doctor, when can how do you decide what to do, basically? So I think the first thing we'll do is we'll talk through the things that you need to think about. So where exactly is the wound, and are there any functional or aesthetic implications? So for example, if it's right in the middle of their forehead, they're a model, that's their whole career, obviously you need to refer that patient. If they're like a 90-year-old woman who just says, I just want to get out as soon as possible, then you don't need to. So it's just using, obviously, your common sense. When exactly did the injury occur? So facial lacerations, they present over a variety of times. So if it happened a very long time ago, it might have already started to heal. And do they really need much happening compared to something that happened an hour ago? Is the wound clean or contaminated? So what was the mechanism of injury? And did they kind of fall on like a muddy road, or were they just hit and elbowed while playing football? That's obviously a much cleaner injury than something with dirt in it. And you can sometimes just see it really clearly. The main thing to ask yourself is there any damage to underlying structures, so vasculature or other structures? So the most common things we see on the face are damages to the facial nerve. So we want to always check all facial movements when they come in with an obvious laceration, to check, is there any need for a nerve repair? And these will obviously need to be referred. And any other structures. So often when they have a laceration to their cheek, if it's deep enough, they can cut their parotid duct, so from the salivary gland here into their mouth. And if you are suspecting that, you can ask for some help in assessing it, or you can check yourself inside the mouth. Are they still producing saliva, or is there a reason that they're not? And they'll often have swelling because the saliva can't actually get out. Is there any tissue loss? I think commonly, especially with forehead injuries, it looks like there is tissue loss, but by the time you fully pull it down, because it's a very thin piece of skin, there isn't. If there is tissue loss, you need some expertise. Can the wound be closed under local anesthetic, or do they need a formal exploration debridement under general anesthetic? So again, this comes back to how big the laceration is, and if it's contaminated or not. If they've had like broken glass in it, for example, it might just be easier to give them a GA and give it a really good washout and clean. And are there any underlying fractures? And then again, we would need to refer to Maxfax or plastics. So with the facial lacerations, when do we refer? So if it's grossly contaminated, I would probably ask for some expertise, and depending on where it is as well. And I think things that are most commonly referred to Maxfax, and I would always refer, are any eyelid lacerations, any nasal lacerations that have exposed the cartilage, anything that crosses the vermilion border of the lip, so where lip becomes skin, and anything on the neck. And that's because those are really difficult to close unless you've done it a few times. Other lacerations, if they're really deep and they need multi-layer closure, then I would refer that. Or if it's just, you'll get obviously a vibe of it, and you've obviously seen a lot of facial lacerations, and just decide, do I need someone or something? And it's difficult because a lot of hospitals don't have Maxfax or plastics on site. So is it worth sending this patient to another hospital to have it looked at, or can a really experienced nurse practitioner maybe do it? And it depends on the confidence of A&E doctors and nurse practitioners as well. Often there are A&E doctors who've done a Maxfax rotation, so they're quite happy to do it. So it's just worth asking around if that is the case. When you do decide what to do, so the first option is do nothing. And that's often an option I choose with young children. It's not worth doing it. They heal really quickly. Like I was saying earlier, the face has a really, really good blood supply. So it's unlikely to get infected and it heals within 2-3 days, really. So if you think it can, just do nothing. Can you steri-strip it? So if it's just a superficial laceration, we can just pop some steri-strips on. Glue, I would only ever use in children. I'm not a big fan of glue because it doesn't do a very good result, and it also can get infected quite easily. So unless they're young children or it's really superficial laceration, I wouldn't use glue. And then if it's deep or big or has functional or aesthetic implications, obviously suture. So how do we close these lacerations? So assess for damage to underlying structures, then give some local anesthetic if you are going to suture. If you're not, then not to worry. Then wash it out really, really well. And that's the most important part of the whole thing. Either with saline, if it's a clean wound, but if you are worried about any contamination, I would use some betadine or iodine-based substance to really, really clean it out. And sometimes it's worth giving a bit of local anesthetic, even if you just need to clean it really well. And then decide in what manner you want to close it and then go from there. With sutures, use dissolvable sutures in children so they don't need another procedure. Otherwise, things have changed because of COVID, but normally we would use non-resorbable sutures in the face because they leave a better aesthetic outcome. But nowadays, some patients say, I can't get a GP appointment to have them taken out. I don't want to take any more time off work. I don't really mind that much, in which case you can just use resorbable sutures. So wound care, this is true of all the wounds. So keep the area dry for 3 to 5 days, and that's because it prevents infection and scarring. Sutures to be removed by the GP or an outpatient department, depending on where it happens, in 7 to 10 days. And they must return if there are any signs of infection, so redness, swelling, warmth, pus, or discharge. And then when patients ask about scarring, I often say, once it's fully healed, so in about 2 to 3 weeks' time, if they use just over-the-counter stuff like bio oil or vitamin E cream, or just ask the pharmacist for any scar revision creams, that works well. And worst case, they can have scar revision surgery in the future. So especially with kids, if you can't get a good aesthetic outcome, it's worth just saying to the parent, worst case at 18, they can have scar revision surgery. So finally, we're just going to briefly talk about dental trauma. And the reason I bring this up is because, as you all probably know, it is getting near impossible to get an NHS dental appointment, and especially as an emergency. So these patients often present nowadays to A&E or to primary care because they just don't know where else to go. So, and it's really important because dental trauma can actually have life-changing both physical and psychosocial consequences. And you can save someone's tooth and save them quite a bit of money as well. So the most important one is if they have a fully avulsed tooth, so the entire tooth has come out intact out of the socket. This is when it's really important for first responders. They need to re-implant the tooth as soon as possible or store it appropriately so it can be re-implanted. So if you don't know how to do it and you're feeling uncomfortable, store it in just a glass of normal cow's milk and get them to A&E or to a dentist and they can re-implant it. Otherwise, you hold the avulsed tooth by the crown, so the bit that's normally out. Rinse the root with just saline or milk, only if it's visibly contaminated. If it's clean and it's just been in their mouth, you can just pop it back in. You can orientate it, so compare it to the other side or to old photos, and just re-implant it and just get them to bite down on a bit of gauze to stabilize it, and then get them to a dentist, so either Maxfax on call or an emergency dentist, and they have a metal splint put in place for a few weeks just to allow that to heal. We've seen this unfortunately a few times, but do not reimplant baby teeth because obviously they're going to lose them anyway. Other dental trauma should all be discussed with either the on-call Maxfax team or an emergency dentist. Emergency dentists can normally be contacted through NHS 111. Some areas, so I know, for example, one of the hospitals I work at in Essex, the whole of Essex has a dental trauma coordinator, and you can call a number and they will always be able to give you advice or find you a dentist to go to. So it's worth just checking in your local area what facilities are available. But if you're ever in doubt, you can just call 111 and they'll pop you through to an emergency dentist. You can see there's loads of things that can happen to teeth. And I think if you're in doubt of what's going on, best thing to do is just stabilize it, get them to bite down on some gauze, or get them not to eat, not to chew on anything hard. And then that time, nothing will happen until they see a dentist. And often then they need some sort of treatment, and it's normally fine. But it's really important to help people not to lose teeth, and it can cost a few grand to kind of repair them afterwards. So that's everything I was going to talk about today. So in conclusion, facial trauma is very common. Always discuss cases that you're unsure about with your senior or a MaxFax team on call. So either in your local hospital or in one of the hospitals around the area, and the A&E staff will always know where the best place is to call. Thorough history and examination are key, and safety netting is really important, because a lot of these patients, like I was saying, are seen in outpatient clinic, and the MaxFax doctor should normally do this. But really important to say, if you have any changes to your vision, any changes to your occlusion, come find help sooner rather than later. So that's everything I was going to go through. And just briefly, before we go into questions, just some really good books. The second one is actually free online through the British Association of Oral and Maxillofacial Surgeons. So if you just Google oral and maxillofacial book, BAUMS, it comes up, and it's really good to have. It's just a PDF, and you can always look things up in an emergency.